Good evening, everyone. So the title of my study is Evaluation of Limbal Microstructure in Early Vernal Keratoconjunctivitis Patients Using Spectral Domain Optical Coherence Tomography. So vernal keratoconjunctivitis, it's a chronic inflammatory disorder of the ocular surface, and it's one of the leading causes of limbal stem cell deficiency. And we know that SDOCT has been described to observe the morphology of palisades of Vaux and the limbal stem cell niche, as well as the limbal stem cell niche microstructure, and detection of subclinical limbal pathology using SDOCT may actually help us do a risk stratification in early VKC patients, and that is the hypothesis of this study. So if you just look at this image, this is a representative image of HNE staining of the limbus. So this is a radial and a tangential scan respectively, and you can make out that the limbal stem cells are in this region, and which can be seen in the corresponding AIOS2025 image. Similarly, in the tangential scan, you can see the palisades of Vaux as these projections, which can again be seen corresponding on the AIOS2025 image. So the objective of our study was to determine the utility of spectral domain OCT for detecting subclinical changes in the limbal microstructure in patients without limbal pathology or other clinical signs of LSCD in early VKC. This was a cross-sectional observational study conducted at Dr. RP Center for Ophthalmic Sciences. The sample size was 30 eyes of 30 patients with grade 0 to 1 VKC as per the Bonini grading, and 20 normal controls were included as well. So the patients had early grade 0 to 1 VKC as per the inclusion criteria, with a normal limbal morphology on slit lamp exam, no clinical signs of LSCD, and patients who were cooperative for SDOCT imaging were included. So an OptoView AIOS2025 machine was used, wherein we scanned all the 4 quadrants of the limbal area, both in a tangential and the radial manner as seen in this image. And our outcome measures, the primary outcome measure was the limbal epithelial thickness in each quadrant, and the secondary outcome measures was the palisades of morphology and the corneal epithelial thickness. Our results are as follows. So the age of both in both these groups were comparable. So was the sex distribution. In the VKC group, 12 patients had grade 0 and 16 patients had grade 1 VKC, and the mean duration of disease in these patients was 11.3 months. So the superior and the inferior quadrant showed a significantly lower limbal epithelial thickness in the VKC group as compared to the normal, whereas in the nasal and the temporal quadrant it was comparable. The central corneal epithelial thickness was comparable in both groups, while the difference in the minimum and maximum of the corneal epithelial thickness was higher in the VKC group, and so was the standard deviation. So these are just the box plots which shows the significantly lower limbal epithelial thickness in the superior and inferior quadrants in the VKC group. And similarly, we can see that the epithelial irregularity, which is depicted by the CET maximum minus minimum and the standard deviation of corneal epithelial thickness, was much higher in the VKC group as seen in these images as compared to the normal eyes, where it was not that high. The abnormal palisades of Vaux morphological features that we studied included dilated limbal vessels that can be seen in the top right of this image, where stromal vessels more than 50 microns was considered abnormal, loss of undulations in the tangential image, the loss of smooth stromal epithelial interface in the radial image, and the loss of conjunctival corneal epithelial junction again in the radial image. So just to make it a little clearer, I'll put in the normal images for comparison. So as you can see that we are able to see these undulations in a normal eye at the limbus in a tangential scan. Similarly, on a radial scan, you don't usually see dilated vessels which are more than 50 microns, and the smooth there is a smooth stromal epithelial interface as can be seen in this normal eye, and also there is a junction between the cornea and the conjunctival epithelium as can be seen in this image, which is lost in cases with abnormalities, limbal microstructure abnormalities. So we observed abnormal palisades of morphology in 83% of our VKC eyes as opposed to 5% of our controls, which was significant, and this is the distribution. So one eye could have more than one abnormal features as can be seen on this table. So we know that clinical changes, it has already been published that LSCD has been associated with chronic VKC. We also know that VKC can lead to cytological changes in the form of goblet cells on the cornea. What our study wanted to do was it wanted to look for evidence of early limbal alterations before clinical LSCD becomes apparent in these patients, and that's what we could see using the SDOCT imaging. Also, the increased variation in the corneal epithelial thickness may be an early manifestation of limbal stem cell dysfunction in VKC patients, which indicates subclinical instability of the corneal epithelial homeostasis before overt clinical LCD develops. So to conclude, reduced limbal epithelial thickness was observed in early VKC eyes with a significantly higher incidence of abnormal palisades of work morphology. Changes on the ASOCT may be suggestive of alterations in the limbal stem cell niche in the early stages of disease when the visible limbal involvement is not yet present. And so SDOCT can be used as a screening tool for VKC patients at risk for LSCD. It helps in easy quantification, detecting subclinical disease, risk stratification, treatment escalation, as well as it could help us guide the follow-up frequency in these patients. However, further studies are needed to evaluate the limbal microstructure in these patients in various stages of VKC as well as in a longitudinal manner with response to treatment. And of course, larger cohorts will further establish these results. Thank you.
You mentioned in your last slide that one of the things it could help you is going in for more aggressive treatment for such patients.
Yes, sir.
The issue is that most of our patients, these are youngsters, the parents come to you for symptomatic relief.
Yes, sir.
They are more interested that the child doesn't have redness, itching, these sort of things. So all eye surgeons do their utmost to see that the patient is symptomatically better, irrespective of the stage of the disease. You follow? So I'm just saying that even if we were to do this test, at the end of the day, I don't think our treatment regime would change in any way.
So it would just give us an indication that who are the patients who are at a greater risk for developing an LSCD in the future. So maybe we can have more frequent.
For this, you need to come to that conclusion. You need to do a longer longitudinal study.
Yes, longitudinal, which is one of our recommendations.
That is done, you cannot say this.
Correct, sir. So that is our recommendation, that we'll have to do a larger cohort and longitudinal study for that. Yes, sir.